Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Cancer Consortium. And my guest tonight is my friend also, Dr. Tiffany Torstenson. Tiffany grew up in Cedar Rapids, Kennedy. What's the mascot of Cedar Rapids, Kennedy?
Cougars.
Go Cougars,
Yeah.
okay. And then went to Simpson College, undergrad. Des Moines University for her medical degree, and then did her general surgery residency at Mercy in Des Moines, and then did a fellowship in breast surgery at Mayo Clinic, returned to Des Moines, where she is a breast surgeon at the Katzmann Breast Center, which is part of the Mercy Comfort Center for Health for Women. Yes. And we're just so glad to have her here tonight. But even more importantly, I have to tell you, I'm so glad to have had her as a teammate for the last 9 years. One of the very first breast fellowship trained folks to come back to Iowa and be in a practice exclusively in breast surgery. Over the course of my career, not Tiffany's, but my career, typically the surgeons that did breast surgery were the same surgeons that removed gallbladders and did hernias and appendectomies and a little bit of everything. And there were, very, very, very good surgeons, but the specialty of taking care of women with breast cancer, I mean, that has changed, and there's so many special techniques, and we'll get a little into that a little bit. So Tiffany, welcome.
Well, thank you. Thank you for having me. And I'm happy to be here. And I'm so pleased to be also a part of your new finding of the Cancer Center. We're very, very privileged, me and Dr. Beck, to go over there and experience that amazing facility. And we just are very proud and honored to do that, Dick. So I just wanted to give
and we'll talk a bit about that,
Yeah.
how just this year that has changed maybe the way that women go through their breast cancer journey. How did you decide? Was it in medical school, or was it during your general surgery residency that you decided that you wanted to dedicate your career to breast care?
Yeah. So when I started in general surgery, you first go in and you're going to, be a brain surgeon or a heart surgeon. You start out, for the sky. And then, the more and more you get experience and you meet certain, surgeons that you kind of idolize, you're like, wow, they're pretty neat stuff. And I had the opportunity to meet Dr. Susan Beck, and she's an amazing surgeon. She kind of taught me about everything I know. And so I would follow her a lot, especially in my kind of second and third year. You kind of decide in residency kind of where your kind of niches or kind of what your passion is. And it was kind of between breast oncology or plastic surgery, because I like the cosmetic side of things, but I kind of was like, I don't want to do cosmetics all the time. And so breast kind of gave me the medical side, but also we can do and dabble in some cosmetics. And so that kind of lured me to that kind of field. And, like Dick said, 20 years ago, we didn't have, breast surgeons, but I feel like breast cancer is becoming so more in detail, the biologics of breast cancer, how we diagnose this. There's certain types that we've now dedicated a surgical field to that. So that's kind of where my journey started, I think, though Dr. Beck was a big part of that. So
how was it applying to go to Mayo for a fellowship? They don't accept too many people.
Yeah, so research is huge, for mostly any fellowship after beyond surgical training. And so I was very fortunate to go down to MD Anderson for actually 2 occasions and work with some of, I worked with lots of the radiation oncologists and some of the physicists to do looking at radiation. We got a poster printed for that. So that was one of my projects. And then we did another.
Was that during your residency,
your
residency?
General surgery residency? That was during my residency. Okay. And then I actually worked with another surgical project. But so you have to definitely do research. And that's kind of what I figured out. And then I also, and letters are important, recommendations and things like that. But it wasn't as competitive. Now it's becoming very competitive. I think how everything is now, And so when I applied, there was about 50 candidates, because we'd kind of see them on the interview trail, and now when I applied, there was, I think, maybe about 30 fellowships. I think now there's up to like 100, and it's
Under different fellowships around the
yep,
country in
around
breast
the
surgery.
different
How long
countries.
was the fellowship?
It was 1 year. So 1
So
year.
for your for those who don't, so your training was obviously 4 years of college, 4 years of medical school, and then the general surgery residency program was how many years?
That's 5 years.
5
So,
years,
yep,
and then
so-
the breast fellowship was 1 year on top of that.
Yep. So,
Yes. So, do you remember back during maybe your either medical school or your residency, taking care of a cancer patient or taking care of cancer patients? What aspect of caring for breast cancer patients that sort of made you realize that that was the career you wanted?
what I really enjoy about breast kind of oncology versus just like the general surgery aspect of it is, you would meet a patient, they have gallstones or they'd have a hernia, you'd see them, 20 minutes, you'd have them in surgery in 2 weeks, and then you'd see them back in 10 days, and then they were gone, and I was like, I really enjoy building relationships with people. I think that's the biggest thing, I have met so many wonderful people, actually one of my patients, one of her daughter's nannies from, like you meet so many different kind of people and you develop these friendships and these relationships with people. And that kind of brought me to this kind of field. And also it's one of the fields, oncology it's sad sometimes. I would love to say every single one of my patients, lives, but I can't say that. But it's one of the oncologic fields that we cure lots of cancer, and that's what I like to see, and so I think it's relationships and that, I can follow them for a long time and they do well through their journey.
Okay. And we're going to talk about the journey. So
Yeah.
we're going to talk a bit about how women first get diagnosed and then the process that happens over time. So one of the most common scenarios is a woman goes in for a screening mammogram. And screening mammogram means by definition that the woman doesn't have any symptoms of breast cancer, that mammograms help find breast cancers before they're large enough to cause any symptoms. So let's have that be, let's say it's a 60-year-old woman who goes in for her annual mammogram. She's been going for 10 years and she goes in and when you have a screening mammogram, you actually get your mammogram and you leave. So in a screening mammogram, a doctor doesn't come out and show you your mammogram and talk to you. You get it done and you leave and you're told, well, you'll be getting a letter in the mail in a week, maybe is what you're told. So if it's abnormal, what's the process by which that woman who just had a screening mammogram that shows an abnormality, what's the process by which you will be notified of the abnormality?
So we have now at Mercy kind of a radiographic tech now, or a navigator for our facility. And so this is the beauty of this. So in most places you get a letter in 5 days and it says we'll be contacting you because it's basically a BI-RADS. You get a score of 0, meaning we see something, you got to come back and we've got to do more imaging. Kind of the beauty of Mercy and our radiology center is that our navigator will get on that phone. And sometimes before you even make it out the door, they'll be calling you, if they have time, and they will bring you back for more imaging.
You're informed, and typically at that point, you're not informed you have cancer because most callbacks and workups end up being benign. So, but we have a human being that calls and says, there was something that showed up in the mammogram that we need to work up a little bit further. We're going to be scheduling you to come back in to do some additional views. And so the patient would come back in, and it might be as soon as the next day, and they'll do some close-up views and maybe an ultrasound. And at that point, those images are called diagnostic images. So when you come in for a screening, you don't have any symptoms. It's called a screening mammogram. When you come back, it's for a purpose, and that's because of the abnormal mammogram. So the actual mammogram doctor will be there in the suite when you have your additional images.
And they will have a conversation with you. And lots of times when we schedule our diagnostics, we will schedule them with the possible biopsy, which is nice. So then you don't have to come back for a third time. So, and they always try, if they find something on the mammogram, they try to match it with an ultrasound, especially if it's a mass associated finding on your mammogram. And at that point, then a lot of times the radiologist will come in and talk to you. And I think our radiologists, we're very blessed to have some very, very good radiologists that work for us, that they will go into a room and kind of speak to you and kind of say, hey, we need to biopsy this. Do you want to do it? And most patients obviously want to get it done that same day. And then depending on how they saw the lesion, so if they saw it very good with ultrasound, they will do like an ultrasound guided biopsy. Or if they couldn't see it by ultrasound, then they will put a patient back in the mammogram machine and do what's called a stereotactic biopsy, because we need that tissue to get that diagnosis.
Yep. And as you pointed out, the biopsy can be done often the same day, unlike some procedures where you've got to fast the night before and not have anything to eat and have a driver there. Fortunately, the breast biopsy in the mammogram suite area is a fairly simple, straightforward, and a lot of times when you're having those extra images done, they can do the biopsy the same day. The results are not known that day, so you're not the radiologist who's there doing the biopsy doesn't have a microscope to look at the biopsy and say, is this cancer or benign? So the next step would be the patient goes home after the biopsy. What's the process by which the patient is informed of the biopsy results?
So that is also kind of the radiology, radiographic navigator, we call her. And so any biopsy done through our radiology department is going to be called by her. Or if it is cancer, a lots of times she will then alert our navigator. So we had 2 surgical navigators, one kind of for Dr. Beck and then one for me.
And those are nurses.
Nurse navigators,
Yeah.
yes. So
And so our nurse navigators are very experienced with cancer. So as you all know, nurses are wonderful, and an experienced nurse has had many, many, many hours of experience talking to individuals. So it's that call to inform someone that they have cancer is a difficult call. And many of you in this room probably know exactly where you were when someone spoke the words, you have cancer. And the information needs to be given clearly, but also with hope and optimism and with a plan for where we go from there. So our fictional patient right now just got a call from your nurse navigator and informed her that the biopsy shows she has cancer. What's the additional information that navigator would give the patient, and what would be the next step?
yeah. So what they try to do is they kind of tell them what kind of cancer they have. It's usually of the ductal or their lobular kind of origin. Those are the 2 main structures of breast. And there's different subtypes, but most times it's going to be a ductal or a lobular. So they kind of tell them that. They will usually go over the grade of the cancer. Now, grade, lots of people get grade and stage kind of confused sometimes. So we grade tumors based on 1, 2, or 3, and it kind of goes with how aggressive those tumors are. And so they try to give them that. And then we also talk about the biomarkers. Biomarkers are huge, in breast cancer. And the biomarkers we look at are the estrogen receptor, the progesterone receptor, and the HER2/neu receptor. Estrogen and progesterone are hormones, and lots of breast cancers are very sensitive to those hormones. And then some breast cancers will exemplify a certain protein called the HER2/neu protein. And so they try to give them that information as well. And then if there was, a possible lymph node that was biopsy, they will talk to that if it's positive or negative or any kind of tumor. So that's kind of the main body that they will talk to them about.
And then will they also have, at that point, an appointment scheduled for them?
Yes. And so then they will have an appointment with Dr. Beck or me.
Yeah. So Dr. Beck and Dr. Torstenson. So up until this point, the patient hasn't seen a cancer doctor. I mean, yes, the radiologists are involved in cancer, but radiologists very, very good, but they're not the the doctors that actually treat the cancer. So oftentimes in breast cancer, the patient will not have met a breast cancer doctor until after the biopsy. So as Dr. Torstenson said, we are blessed that we have two breast cancer surgeons that are dedicated their life to breast cancer, and they're both at the Katzmann Breast Center. So they'd get scheduled to see either Dr. Tiffany Torstenson or Dr. Susan Beck. Then what would your first meeting with a patient who's had mammograms, diagnostic, and a biopsy?
Yeah, so the first meeting, what I always do is, I learn a little bit about my patients, kind of where they're from, and they learn about me. And then kind of what we first do is we really go over the path report, because path reports can be very overwhelming. There's lots of information in those path reports, and lots of it's kind of the pathologist driven, and so we really try to go over that. I kind of call it the Bible of the cancer, because this is kind of how we base lots of our treatment on. And so I kind of go over the things the navigators went over them in a little more details. We kind of look at some pictures about how lobular cancer looks under a microscope, or ductal cancer looks under the microscope. And then I also go over their imaging. We talk about density lots of their breast, and then also at that time, we kind of decide treatment plan or what additional studies are needed. And so I think that's kind of what we'll touch on next here, is because lots of times it just doesn't stop with a mammogram or an ultrasound. We are using MRIs a lot now. MRIs change our plans about 30% of the times, and MRIs are a very, very sensitive radiographic study. I think it's kind of like it's a very big roadmap of our breast, not just looking at the cancer side, but it looks at the contralateral side or the opposite side as well. And it will also look at lymph nodes and stuff. And so many times we are doing an MRI prior to any, whether it's surgery or starting with chemo first. And then also sometimes we have to do what's called a PET scan too. Now, if their lymph node is positive or skin is positive or they have a very large tumor, we always want to make sure that cancer has not gone to other parts of the body, because that has to do with staging and also guides us in treating these patients.
So the MRI is done to look more closely at both breasts and at the lymph nodes that are near the breast. But a PET scan would be done primarily to look for any cancer that might be in other parts of the body.
Yep.
So, and then the deciding on the plan of care. So in olden days, maybe 10 years ago, 20 years ago, it was surgery first, and then after surgery, okay, do they need chemo or do they need radiation? So it was surgery first, and then do you add the other things? Now, with many types of breast cancer, we might actually start with chemotherapy up front and wait and do surgery later. What are the circumstances in which you would recommend a woman receive chemotherapy before she has the surgery?
It's a great question, Dick, because, some of my nurse practitioners, so there's not really a gold standard on when we give neoadjuvant.
And the term neoadjuvant
Yes.
means giving the chemo first. So when you do surgery and then give the chemo after surgery, we call that adjuvant chemotherapy. When you bring the chemotherapy before surgery, we call it neoadjuvant, meaning new first. So when do you give neoadjuvant chemotherapy?
So that's a great question. I still, from my fellowship, I have a little thing that my Dr. Bowie, who is she's kind of a world-renowned surgeon and a researcher, just had this little sheet of paper in her office and kind of wrote down what she thought neoadjuvant patients should undergo. So I still have that always sitting on my desk. It's funny how we gravitate to that stuff. So when I consider neoadjuvant, any locally advanced breast cancer or an inflammatory breast cancer. So, just to kind of decipher them quickly, locally advanced breast tumor is maybe one that's involving the skin, can fungate, lymph nodes, are always taken in consideration as well when you're considering giving chemo up front. HER2 status is big. We really push for neoadjuvant. Mostly my kind of cutoff is about 2
for
centimeters
HER2 positive.
for a HER2 positive. Yes.
So HER2 positive tumors tend to
Yes.
be a bit more aggressive, but there's special targeted medicines that have been invented to treat HER2.
Yes.
So first indication would be a locally advanced, which is described as a big tumor or one that involves the skin or a lot of lymph nodes. So that would be a locally advanced where you would do neoadjuvant chemo first. Second indication would be a tumor that's HER2 positive. They tend to be more aggressive, but there is a special medicine that can be used. And so HER2 positive, not every HER2 positive,
No,
like a very small
yeah.
tumor that's HER2 positive, you'd probably still do surgery.
Yeah, I think 2
First.
centimeters is about kind of where I
Okay.
kind of start leaning to that point
Okay.
when they're over 2 centimeters. And then our triple negative breast cancer, so those are overly aggressive tumors.
And what does triple negative mean?
So those are tumors that those biomarkers, the estrogen, the progesterone, and the HER2 are all negative. So they have no basically stimulation. They're just growing, but they have no kind of anything that's stimulating them to grow.
And triple negative tumors tend to be the most aggressive of the breast cancers. So the most favorable is estrogen receptor positive, progesterone receptor positive, HER2 negative. That's the most least aggressive of the breast cancers. And the most aggressive is negative, 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 triple negative. So triple negative breast cancer, again, if it was a really small breast cancer and the lymph nodes weren't involved and it was triple negative, you still might do surgery first. But once it gets to about 2 centimeters and it's triple negative, then we know that it can be more aggressive. And so we tend to move the chemotherapy up front before the surgery.
And then the kind of the gray zone, and we're learning more about this every day, are tumors kind of called our luminal B tumors. So those are kind of our maybe a grade 2 or grade 3 tumor that can be estrogen positive, kind of low progesterone, and lots of them are in HER2 negative. And so in those cases, we kind of look at, and sometimes we do genetic testing on the tumor. That's not genetic testing of the patient. And we have a recurrence score, and it tells us if it's kind of like a bad actor or a high recurrence or a low recurrence. And so we're using these tests to help us guide in these kind of gray areas where should we doing upfront chemo on these luminal B tumors? Definitely if they're involving lymph nodes, yes, we do. But sometimes if you have let's say a 3 centimeter luminal B tumor, before we give you chemo, we want to know that it's going to help them. And so we're using these genetic studies a lot more to help us guide us. So
Tiffany, can you explain the difference between a person going in and getting genetic testing? Like, do I have the BRCA gene? Do I have genes that I inherited? Do I have genes that cause cancer that I might give to my kids? So genetic testing, what's the difference between genetic testing and then the difference between that and doing genomic testing of the tumor cells?
That's a great question. And I think that kind of confuses patients sometimes. So your genetics, you get 50% of your genes from mom and 50% of your genes from dad. And so we all have certain genes that are supposed to protect us from getting certain types of cancers. It's just not breast cancer. There's, genes that protect us from colon cancer, all different sorts. And so what they look at is, that's the beauty of working with a genetic counselor, is that if you qualify, that means if you have lots of family history of, breast, ovarian, colon, prostate, even gastric cancer, they will kind of decide a panel that will look at those genes that are supposed to protect you from getting cancer and see if there's any mutations in them. And so that can explain lots of times why women have breast cancer. So that's your own genes. But the tumor also has its own set of genes. And these tests, and you guys have maybe heard of tests called Mammogram and Oncotype. Oncotype is probably the one we probably use the most, but there's also Mammogram. And those look at the genes of the tumor itself to let us know how kind of aggressive that tumor is, or basically tells us if it's a high recurrence or a low recurrence. So those two genetics test kind of are two different separate, basically, set of genes we're testing.
And those can be helpful in determining whether the patient's cancer cells are likely to benefit from having chemotherapy or maybe just hormone therapy. Just saw a patient today. She was grade 3. So the pathologist, using the pathologist's eyeballs, looking at the slide, saying, is it a 1, 2, or 3, with 1 meaning least aggressive, 3 meaning most aggressive, said it was a 3. But when we did the oncotype, it came out with a really low score, saying that the chances of chemotherapy providing any benefit is less than 1%. And that hormone therapy alone, meaning anti-estrogen treatment, was going to be sufficient for this patient. And that was a patient where, with a grade 3, there might have been leaning toward, we'd better do chemotherapy. But the genomic testing of the cancer cells that looks at many more things than just what a pathologist's eyeball can see on a microscope slide gives much more accurate and predictive information.
Yeah. And it's really beneficial because, kind of like you said, probably 20 years ago, that patient probably would have got chemo. And we're using also those tests even to guide us in node positive patients. 20 years ago, having nodal, disease was always an indication for chemo. And now we can use these studies that patients usually between 1 and 3 nodes that are positive to also help us. Because sometimes we think, oh gosh, this lady had, 2 nodes that are positive, and then you get your recurrence score back and it's low, and she got to miss chemo, which is, obviously is wonderful.
So it's kind of the American way is always to do more, but in certain types of cancer, like breast cancer, where the cure rate is so good, actually a lot of the focus now is, can these tests help reduce the aggressiveness of our treatment to get the same results and spare a lot of toxicity? So that has changed a lot of what we do, not only in breast cancer but other cancers. But now we're following this patient on her path.
Yes.
And so let's say that it was a triple negative and a lymph node was involved. And we have a multidisciplinary cancer conference for breast cancer. It meets once a week. Every case is presented. The surgeons are there, the radiation oncologists are there, the medical oncologists are there, the pathologists are there, the diagnostic radiologists are there, the genetic counselor is there. So this patient has also had genetic testing and doesn't have any genes that she has that caused the cancer. The genomic testing was done, and there's a high score, and it's triple negative. So the breast cancer conference meets and recommends neoadjuvant chemotherapy, so chemotherapy before surgery. Dr. Torstenson, as a surgeon, when do you have the conversation with the patient about, okay, I'll start with the chemo, but I know I'm going to have surgery. What are my surgical options?
Yeah. So with a triple negative breast cancer, these cancers are going to, and I agree with Dick, I would definitely recommend neoadjuvant for her. But, and that usually comes at our first meeting, especially when you have a triple negative breast cancer in this. So you kind of know their path in the beginning. So you kind of start prepping them, like, we're going to get you into the medical oncologist. We're going to start the neoadjuvant chemotherapy, probably get an MRI, prior to her chemo, and then an MRI when she finishes, kind of what we start with and what we end with. And our goal, and I feel that, 20 years ago, I think we did lots more mastectomies. I feel as a surgeon in this day and age, I really want to push for breast preservation and radiation, because we know based on multiple studies that women do very well and about equivalent to the recurrence rates and overall survival if they would have a mastectomy. So sometimes big is not always better, we always say. So lots of times the neoadjuvant will, let's say they have a 4-centimeter tumor at that point. Let's say, I don't know what we sized her or not, but let's just say she was 4 centimeters. And that tumor is going to shrink because it's an aggressive tumor. Chemo attacks aggressive cells. So we can talk to her about having a lumpectomy at that point, and if she's interested in it, that is our goal. And so that just also spurs us to do the neoadjuvant because one, we could get her down to maybe even half centimeter or centimeters, which is going to make her surgical outcome much easier and also make her a lumpectomy candidate. So we definitely talk about surgery prior to the chemo and to see kind of where their goals at. Now, some women just look at me and say, Dr. T, I know what you're saying. I know the data. I know the overall survival is the same, but I'm having this breast off,
So there maybe 3 options, and you can probably come up with other options. So you use the term breast preservation and lumpectomy. So obviously that means you just remove the breast tumor and a rim of normal breast tissue around it to make sure you get it all. That's the lumpectomy. You sample some lymph nodes. That's a sentinel
lymph node
biopsy. So that would be one form of treatment. A second form of treatment would be like a mastectomy on the side that you have the cancer.
Correct.
But another surgery option is to have both breasts removed. It's called a bilateral mastectomy with or without reconstruction at the same time. Under what circumstances would you recommend the lumpectomy versus one-sided mastectomy versus bilateral mastectomy with or without reconstruction?
Great question. So a lumpectomy, you have to have a good breast to tumor ratio, okay? Because obviously if you have like an A-sized cup and have, a 4-centimeter tumor, you're not a good candidate for it because we're taking too much breast tissue out and we're going to leave you kind of disformed and stuff. And lots of that decision is also patient driven. Some women know coming in, they don't want to keep the breast. But definitely before lumpectomy, you have to talk to them about breast to tumor ratio. That's the biggest kind of thing. If they've had, previous cancer or radiation, they can't have radiation again. So then the standard of care in those kind of patients is to undergo a mastectomy. When it comes to what kind of mastectomy, there's different types of mastectomies, okay? There is kind of what I call cosmetic mastectomies, which we try to preserve the skin. That's called a skin sparing. Or if we try to preserve the nipple, which is a nipple sparing. And those two mastectomies have to have reconstruction. Those are the cosmetic mastectomies because we want to keep that envelope of the breast as normal as possibly so an implant or tissue, kind of our adipose tissue or basically our fat tissue can go replace that breast.
So let's talk a little bit more about that. Because I have to say, the first time I saw a patient who came in to see me said that she had bilateral mastectomies, and we opened the gown, and there visibly is all of her skin, her nipples, and 2 breasts. And it's like both of your breasts have been removed. So that concept, when a woman has nipple sparing, and obviously you're the surgeon, when you see it after, all of the skin is there, the nipple is there. Dr. Torstenson has removed the breast tissue that's under the skin, and one of the plastic surgeons has placed tissue or implants in there, but you actually see visibly what looks like their breasts.
Yeah, it's
so
amazing.
Talk a little bit more about performing a bilateral nipple-sparing mastectomy and the role you play and the role the plastic surgeon plays.
So when a woman chooses a mastectomy, I was going to kind of answer about kind of the bilateral. When women choose to do the other side, it's more for risk reduction. It's about a 97 to 98% risk reduction for future breast cancer. Everyone says, well, Dr. T, if you remove it, why could I still get breast cancer? And there are still some ducts and lobules that can form in the future, but it's strictly for risk reduction, and that's what women choose. And they also choose it for cosmetics reasons because a reconstructed breast does look different than a native breast, and so they want to be symmetrical. And when it comes to the nipple sparing, yes, those are kind of we've been doing them now for probably 10, 15 years. And we want those patients to look like they've almost had an augmentation. You know, that's our goal. We want them to look like they went and had a cosmetic procedure versus a cancer surgery. And that's kind of our goal, you know, obviously oncologic safety, but also we want, you know, them to be feminine. They want to be good in a bathing suit. They want to feel still good in their clothes. And the beauty about that mastectomy is we do it like a incision underneath the fold and stuff. And so the breast kind of hangs over there. So you barely can even see the incision. We test the tissue underneath the nipple because we are leaving more tissue, which, you know, people get worried could that harbor cancer down the road. So we take what's called a retroareolar biopsy, or just basically a biopsy behind the nipple. And we send it to a pathologist while we're operating, and they will tell us if that biopsy is clean. So then we know we're safe to keep that nipple and that areola intact. But it's a very beautiful procedure, and women are very, very happy with it. It's a tougher procedure, you know, because it's a small incision, and, you know, we're working down here to get way up here to the clavicle to take that tissue. And the best way, like I describe it to patients, and, you know, it's 'tis the season, we're getting close to Halloween. So it's like a pumpkin. And honestly, when you carve a pumpkin, you carve the top, and, you know, you take the top off and you can scoop out everything out of there. And if you put the top back on, you would never know on that pumpkin you took off kind of the inside of the pumpkin. And that's kind of how I explain it. It's like we just go and take the breast tissue, we close the incision, and it looks like you have your normal breast tissue. So.
And then with the bilateral nipple sparing, there's a plastic surgery component because you've taken out all the breast tissue, so you need to put something in there. What are the different things you can put in the pumpkin?
Yes, the pumpkin, that's right.
Before you put the lid back on.
Yes. So the most common is what we call implant-based reconstruction, okay? That can start with a direct implant. That means that there's no additional surgery. Women who have an implant base right away, though, are mostly smaller women, okay? Because it's harder when you're larger breasted to fit that implant to make it look good. So some women can go directly to an implant. Some women have to have a temporary implant called an expander, and that goes in the day of surgery or after I finish the mastectomy, and that is filled up either with air or saline over a period of months to get them to the size they want.
Slowly expands.
Slowly. Yes, and expands that skin, as well as if also for radiation purposes, if they need radiation afterwards, the radiation kind of causes some tightness to that. So we want to expand that skin before we start radiation, or before we give the patient back to Dr. Deming to start. And then the last case is what we use is called a deep flap, and those are very, very big surgeries. That's where you kind of actually get a tummy tuck out of it, which is kind of nice, but they basically take kind of the lower fat kind of pad of a woman and take both sides of that and bring it up and connect the vessels that are supplying the blood to that fat to the vessels under here in the ribs. So they do have to cut some ribs, but it's a very, very natural kind of reconstruction versus, you know, having that implant, which is unnatural, where as women, they feel much more like your native kind of breast tissue because it's your own fat.
So that's the bilateral nipple sparing. And that is done in combination with you and a plastic surgeon. And we mentioned the 3 different types of implants that can be done. The radiation, maybe we should talk a little bit about which women need radiation after they've had their surgery.
Yeah. So most of the time, and granted, you know, we're always getting away from treatment, and Dick, you can cut me off here if I step out of turn here. Lumpectomies, we know, do better with radiation. It comes down to recurrence rate. So most, you know, every time I do a lumpectomy, I always send them to the radiation oncologist, and then they can have that decision, you know, is it going to benefit? Is it not, you know, and sometimes we're not doing it, you know.
So standard, the NSABP study that showed that lumpectomy was equal to mastectomy and cure was a 3-arm study. So the breast cancer women, a third of them received a lumpectomy without radiation. a third of them received lumpectomy followed by radiation, and a third of them had their whole breast removed, a mastectomy. And the study showed that the women who had the mastectomy and the women who had the lumpectomy followed by radiation had the same low risk of recurrence. The women who had the lumpectomy without radiation had about a 30% recurrence within the breast over the next 10 years. Now, fortunately, those women who participated in the study, they still ended up having a high cure rate, but they subsequently had to have a mastectomy. So that study, that was, almost 50 years ago now, was what showed that a lumpectomy with radiation was equal to a mastectomy. We talked about how we're trying to now with high cure rates, trying to see, are there some women that don't need chemotherapy that we thought they used to need chemotherapy? The same thing is being done with radiation. Are there some women whose tumors are so favorable that even after lumpectomy, they don't need the radiation, meaning the risk of recurrence is so low? And so there are now studies looking at women over the age of 70 that have a fairly well-behaved tumor that isn't very big, that it's hard to prove that they're adding the radiation provides them much benefit. So you're going to see more and more situations where instead of just, you had a lumpectomy, you have to have radiation even though you're 90 years old. I mean, some types of breast tumors would take so long to regrow that the older a patient is and the more well-behaved the tumor is, the less likely that it's going to recur in that patient's lifetime. So that's where age factors in, because slow-growing tumors take maybe 20 years to grow. And if your life expectancy based on your age and all of your other medical risks is such that that's not a realistic life expectancy, then adding the radiation in probably isn't necessary.
Yeah.
So more and more, we're going to be looking at the individual patients, and we'll probably be looking at some of those genomic factors on where we're looking at the actual Mary Doe's breast cancer cells based on all of the genomic markers. We'll probably have more and more information that will allow us to personalize the care. So rather than just saying the guidelines, this patient needs chemo, this patient needs radiation, there'll be individually decisions made based on the patient's own tumor.
Yeah, and just to add to that, we kind of, 70 is also kind of the age where Dr. Beck and I are not doing nodal surgery on some of these tumors. We would always on invasive tumors take some lymph nodes out, check them, make sure, the breast cells haven't traveled from the breast to the lymph nodes. But in favorable tumors, in women who are in their 70s, we are getting away from doing those sentinel node biopsies or checking those lymph nodes.
So one of the characteristics of breast cancer is that breast cancer is more common the older we get. The older a woman is, the more likely the breast cancer is going to be a slow-growing, well-behaved, indolent breast cancer. So much more common to have breast cancer after menopause. The younger women can have more aggressive tumors. And so not only do they have a longer life expectancy where they might benefit from the treatment, but their tumors tend to be more aggressive than the typical run-of-the-mill breast cancer that happens in a 65, 75-year-old woman.
And so going back to the radiation, mastectomy radiations or post-mastectomy radiations. So I always tell my patients there's about 3 reasons why, I would recommend or I would get you to the radiation oncologist. I always say, a tumor greater than 5 centimeters, and that's an invasive tumor. Sometimes we have, pre-invasive or DCIS that's large, but we don't radiate that. So it has to be an invasive tumor of 5 centimeters, a positive margin. That means sometimes if we can't get space between the tissue and the skin and that margin becomes positive, we would send them to the radiation oncologist. And also lymph nodes that are positive. We're radiating patients with 1 lymph node. It, used to be 3 to 4. It used to be. And so That is always a discussion these
Yes.
days.
So generally speaking, a patient that has a lumpectomy gets radiation. That's the general speaking. As I mentioned, some might be able to avoid it if it's very well behaved. Most women who have a mastectomy don't have to have radiation, but some women who have a mastectomy, if they've got a large tumor or multiple positive lymph nodes or a positive margin, then they might benefit from the radiation even after the surgery. Radiation has changed over the years. So what we've done with radiation, we're much more accurate and precise in using smaller fields. So we've been able to go to a higher dose per day, which results in fewer treatments. So classically, when I started here at Mercy Cancer Center 33 years ago, women would typically get about 33 radiation treatments if they've had a lumpectomy. And now it's down to about 15. So we do a higher dose per day, fewer treatments, cure rate's the same, the cosmetic results are the same, but it's much more convenient for the patient and less expensive for, the overall healthcare in general. So that would be the radiation.
Yeah.
How about 5 to 10 years of a pill that's kind of an anti-estrogen? When do women benefit by taking what we call hormone therapy? And what is in breast cancer, what does the term hormone therapy mean?
It's funny because we say hormone therapy, and so people are like, oh, you're going to give me a
The
hormone, Dr.
estrogens?
T? I'm like,
No.
no. So that kind of comes into surveillance a little bit. I mean, we also use those pills sometimes, prior to surgery too, which we'll get into or we can talk about. But there's basically 4 drugs out there that the medical oncologist will talk to a woman about who has a hormone positive breast cancer. So that means, the estrogen is positive, and that's the one receptor we really focus on. These medications, what they do is they help our body convert estrogen to not in its form to basically stimulate growth in our breasts, because the problem of the estrogen, it's a growth factor. It's great. Estrogen's great when we're, teenagers and we're developing breasts. That's great because we have all those helper cells to recognize the cells that turn into bad actors. But as we get older, we don't want that estrogen stimulating growth in our breasts because we've lost the good cells that kind of pick up the cancer cells to kill them, or what we call apoptosis. So these pills go in and block this estrogen, and it helps, one, to decrease recurrence rates, but it also, if a patient has a contralateral side, protects that breast from also developing breast cancer. So I think the medical oncologist quoted about a 20 to 30% risk reduction. But along comes some side effects with those medications. Some of those medications, like the biggest one and the oldest one is tamoxifen, can be given to both pre and postmenopausal women. But the other class, which is a newer class of drugs, is called the aromatase inhibitors. The most common are like letrozole and anastrozole, but those can only be given to postmenopausal women. And some women say, well, why is that? Because actually they block the estrogen in a premenopausal woman who is ovulating. It stimulates the ovaries to go into overdrive. So it's almost a fertility drug. And actually, letrozole is used as a fertility drug. So we don't want to use those in a kind of a patient who is still having periods. So
that's as Dr. Torstenson said, the hormone therapy, the pills that actually block the estrogen, are usually added in after the breast surgery, the radiation, and or the chemotherapy for those women who have an estrogen receptor positive tumor. And it's considered adjuvant. So at that point, the woman is likely cured of her cancer, but it reduces the risk of a cancer coming back in the breast where she had the cancer or in the other breast as well. But that's 10 years of taking this pill. If the pill had 0 side effects, every woman would probably happily take it, although some would forget. I mean, it's like taking a vitamin in the morning. Maybe 2 days a week I remember to do it. But it has side effects. And at some point in time, and it might be 1 week after they start, or it might be 6 months, like, I've got to take this for 10 years? Maybe I'd rather die of breast cancer.
I've
I'm
heard that
being
before.
only a little bit facetious, but some women have significant side effects from the hormone therapy, and so when someone has finished their cancer treatment, and then, oh, by the way, here's this medicine for 10 more years, and I thought I was cancer free. Why am I going to take that whole philosophical concept of, is this pill treating the cancer I had? I'll take it. If this just preventing a cancer, what's the chance I'd have a cancer if I didn't take it? And we have a hard time being real accurate in predicting that. How do you answer that question?
This is what I always say. It's funny because me and Dr. Beck always say this because I feel like we don't give those drugs out. The medical oncologists, I do get some tamoxifen for some patients, but when it comes down to cancer, we send them to the medical oncologist to run that. And I feel like they always complain to the surgeons about it. Maybe they complain to you because I'm like, well, have you talked to, your medical? They're like, no.
Well, you're a woman, and
yeah.
And the side effects are,
yes.
sort of those menopausal side effects.
Yes. And so this is kind of what I tell them. So there's ways we can mitigate some of those symptoms. Okay. And the biggest, symptoms are for the aromatase inhibitors are kind of the joint pain, kind of the achiness, and then the bone loss. But they don't really feel the bone loss. That's more something that the medical oncologist can give you, but it's more the menopausal symptoms. It's the hot flashes. It's painful intercourse. It's those kind of things, the nuisance, hair loss sometimes, weight gain,
emotional ability,
definitely,
tears.
And so there's ways to kind of counteract some of that. Now I always tell them up front, it's not going to go away completely, and I also tell them, if it's in the first month, you got to give them about 6 to 9 months. That's what I always say. Your body does adjust and it will get better. But we also will help them, and sometimes the medical oncologist will help them with, vitamin E, oxybutyrin. It's things to help with hot flashes. There's Effexor. It's actually an antidepressant, but at a lower dose, it really helps with hot flashes. And then, if it gets to that point where those things aren't working, we also at the Women's Center have a menopausal specialist, and her name's Dr. Stratton. And she's very, very good at treating our cancer patients, not putting them at risk, by putting them on hormones, because we don't want to counteract the effects of the drugs. But there's lots of kind of homeopathic things that she can do for patients that really do help. So, and then some patients, we try all that stuff and they look at me and they're like, we're not here to make your life miserable, I always say, and I think Dick would agree. And sometimes it just doesn't work. And some women have tried all 4 of them and it doesn't work, and it's okay, and sometimes they look at me and they say, is this okay? I'm like, it's okay.
It's great. Yes.
It's okay.
There's risks and benefits. And there are some women who 10 years of it is just not compatible with a good quality of life.
Yeah. It is. And it's all about quality of life, especially, after cancer, that's one thing, cancer is horrible, but it also teaches you, I think, that life is short, and I think people, have said to me, some of my patients, that I would have never done this before cancer. And I'm sure you get that all the time.
Right.
And so we want to make, their lives great. We don't want them to be sitting there just profusely sweating and can't do anything or go outside, but we do have ways to mitigate some of those side effects.
We're going to have you back because we're almost at the end. I want to leave some time for questions. So we did want to get into the whole concept of after breast cancer. And so what is survivorship like, and how do we, and so we'll talk more about that specifically, but I do want to allow, because we have quite a few people here in the room with us, our live studio audience, and then we have live streaming. So we'll open it up to questions. We've got a microphone right here.
All right.
Angelina, you get the first question.
Well, I can say, not that you paid me to say this, I have 2 awesome doctors. These are my doctors. Dr. T, we call it, is a great surgeon. So thank you. The navigator was really good. I mean, she explained a lot. She goes, are you okay? Is there any question? No. I mean, she really explained it. But then I said, oh yeah, my husband's in the lobby. I guess we should have brought him. But I go, how do I tell him? She goes, tell me I have a little bit of cancer. And I'm like, that's like telling mom a little bit of pregnant. And we both laughed because we realized that didn't sound right. She goes, I probably shouldn't have said it that way. I don't know. But I do have a question about the chemotherapy. Like for my case, I had 2 different types of chemo with the steroids. So I had a choice of 4 cycles and 6 cycles. And I never thought of asking what was the importance of the steroids? What was, the purpose of that?
So the steroid is to more mitigate symptoms. Okay. So the steroid is actually really good for anti-nausea medication. We all know, we've seen patients, who get very nauseated with chemo. Steroids were great for the nausea. So that's mainly. Sometimes also people get reactions from the chemo and rashes and skin things, and it can kind of drop down the histamine. The problem is, though, the steroids can keep you up and they can cause you to get puffy and they can affect diabetes. So there's always that win-win. But steroids, that's kind of why they do. They pre-medicate you basically.
Helps decrease the side effects of the chemo you're getting that day.
I had no idea, but yes. And vitamin E does work.
Yes.
And I had to switch from Losatrol to Astrotrol. Big difference. It's your body trying to adjust.
Yeah.
So it can happen. It works.
Another question, either from our live studio audience or our live streaming.
What are some of the particular side effects of the radiation you're trying to avoid?
So the side effects of the radiation, if we're treating the breast, number one, you get like a sunburn of the breast. But when you treat the breast, you also treat the underlying pectoralis muscle. And depending if the lymph nodes are not involved or not, you might add in those other lymph nodes. If you have to add in the lymph nodes, then it increases the risk of getting lymphedema, swelling of the arm. And the bigger the field is, there's some women who will get a myositis, just an inflammation of the underlying muscle with some tenderness. And you can also get a little bit of fibrosis, meaning a little bit stiffer, not quite as elastic. And so the side effect that you get while you're going through the radiation is more the sunburn. The side effects that happen as scar tissue develops is the greater risk of lymphedema and just thickening and stiffening of the muscles of the chest wall. One more. This will be the last question.
Dr. T, 2-year survivor in October, thanks to you and Sue and Dr. Deming and others. Seeing a lot of people I know diagnosed younger and younger, a lot of young adults being diagnosed. Are we just screening better? Do you think there's environmental things going on? Why do you think so many so young now?
I think both. Okay. I think that I think we are screening. I think breast cancer is not as taboo as it used to be. We're very open about it. We are pushing for screening and I feel that women are coming in at 40 and getting their mammograms, more than I think they used to, because I think someone knows a friend, someone knows a family member, we all know someone with breast cancer. So I think we're out a little more heightened awareness, and I think also, we know that women very young can get breast cancer. So I think it, scares that kind of population at that point. So I think it's better screening, better community outreach and talking and, just personal experience. When it comes to environmental, I really feel that, obesity is a big culprit of this. We have fast food, it's easy, processed foods, and I mean, that's a whole different subject to get into. But, I think the overall health of patients, is there. So I think there's lots of environmental factors, and that's where I and Dr. Beck and I are really trying to kind of devour and get into it and we have one of our nurse practitioners looking into like a metabolic syndrome and looking at that, trying to get those things under control. But I think it's a combination of both that's really affecting our younger patients who are diagnosed.
I would say I'm open to the possibility that we're exposed to more chemicals in our lifetime now. I mean, in the upper Midwest with agriculture, the the pesticides and herbicides and trace chemicals that are getting into the water, it probably has some factor. And then all of the plastics that we're exposed to may also contribute. The other thing I would say is we are seeing cancers at a younger age throughout. For example, colorectal cancer screening has just moved down 5 years because we're seeing more. With breast cancer, I would also be wondering about, we're seeing the beginning of menstrual cycles happening younger and younger. And is there something that has to do with our lifestyle and or what we eat and or what we're exposed to? Or is it just part of our evolution as a species that some of these things are happening earlier and may contribute? Those are just hypotheses. So unfortunately, we're going to have to wrap it up today, but we will have you
No.
back, Dr. T. This has been
All right.
great.
It's been very
Thank you
fun.
so much
Yeah.
for being on our team and
Yeah.
for being here this evening.
Yeah. Well, I appreciate. Thank you guys for having me. You were a great audience. You know where to find me, just down the road if you ever need anything. So I really appreciate it. I had lots of fun today, and I hope you guys, kind of learned a little bit about breast cancer and got some questions answered.
And thanks to all of you
Yeah.
that are watching. If any of you think that this is a program that people who would benefit by watching it, tomorrow it will go available on demand on the Above and Beyond Cancer YouTube channel. It'll also be available to watch on demand at the MercyOne Cancer website. So please share that news. And I hope you'll join us again next week. Thanks, everybody.
Mhm.